Okay, so good evening, everyone, and welcome to the next installment of the BOMS Journal Club, which is part of the BOMS Educational Webinar Series. Tonight's session is kindly sponsored and supported by WL Gore, and we're very grateful for their support. As I do always, I'm going to give you the dates of the next two BOMS educational events. The first is in 2 weeks' time, on the 26th of May, same time, 8 o'clock BST, British Summer Time. And we're hoping to have Ali Aminian, who's the director of the Bariatric and Metabolic Unit at Cleveland Hospital. So he will be giving us an excellent educational webinar on metabolic surgery. The next Journal Club will be on the 9th of June, same time, 8 o'clock BST, and that will be run by the Imperial College Bariatric MDT in London. Tonight, we've got a really fantastic set of presentations. The team at Birmingham Heartlands will present, and that will be chaired and led by Tom Wiggins. With me on the panel this evening to host and also address some of the questions, we have great pleasure in introducing Dr. Raman Goel, who's the immediate, as in within a few days ago, past president of the Indian Association of Gastroenterology Surgeons, and he's also a very senior and respected bariatric surgeon in Mumbai. So thank you very much for joining us and welcome, Raman.
Pleasure is all mine. Yeah. Hello.
We have, thank you very much. And we have Prof. Kerrigan, president of BOMS, and Vinod Menon, who's president-elect of BOMS, also chairing, and of course, Roxana, who's the trainee rep. So without further ado, we'll bring on Tom Wiggins. So Tom, if you can put your camera on, we'll mute ourselves. And if you'd like to introduce the two speakers, and it's going to be a 13-minute presentation, IHP paper first, 7 minutes for questions, followed by the surgical paper. And we need to be finished in approximately 40 minutes time. And as always, the session is recorded and will be made available to BOMS membership. So thank you very much for supporting tonight, Tom.
All right, thank you very much. Evening, everybody, and thank you for the opportunity to present from Birmingham. As Sharif said, we've got two talks. First one's going to be our IHP talk given by Rachel, followed who's one of our clinical psychologists, and then it's one of our registrars, Rob, giving the second talk. So I will pass over to Rachel, who's going to give our first talk.
Hello, thank you, Tom. I shall just try and share my screen with you now. Can you see that okay? Am I sharing? Yep, lovely. Okay.
Sorry, Rachel, we can see the preview slides.
Yeah, sorry, I was going to say.
Swap over. I don't know if you've got to at the top, it says display settings. If you click on that and then just click the swap.
Okay.
Swap,
there we go. Over. Is that better?
Hasn't come through just yet. It seems to, I think it's frozen.
Is that any better?
No, we can just see the black next preview slides.
Okay, let me stop and try again. Sorry, it was working fine a minute ago. Anything now?
It's working, we've got your preview. Have you got two screens on your computer, Rachel?
Yeah, let me unplug one.
I think if you unplug one, because it's probably sharing the other one. Sorry about this, everybody, but we'll be there in a second.
Okay, I'm going to stop and I'm going to start again, and hopefully this time. Any luck now? I really apologise.
All right, don't worry. I think try and get it up again, and then if not, I think we go with the...
Yeah, I keep trying.
That's right, that's right. At the minute, we've got you.
Well, that's better than nothing, just about.
That looks better. So
is that better?
Perfect. Well
there we go. We get there in the end. Apologies for that. So, my name is Rachel Strachan. I'm the lead clinical psychologist for the weight management service at Heartlands Hospital in Birmingham. I've been there for about 4.5 years, and I do just work in the tier in the tier 3 service, not in the tier 4 service, but I'm hoping that this is relevant to everybody. And I'm just starting my timer just so I can keep an eye on time. So the paper I'm going to present today is this one. It's "Can a short screening tool discriminate between overeating and binge eating in treatment-seeking individuals with obesity?" And that's by Manas et al. And it was published just last month. So just thinking initially about what we know already. What we know is that 80% of people with bulimia nervosa or binge eating disorder have overweight or obesity. So it's a large percentage of those patients do have overweight or obesity. And most of these patients seek treatment for weight loss rather than for an eating disorder. So I think given the kind of preoccupation with weight and shape and body image issues, people's focus tends to be more on losing weight than it is on the eating disorder, and people often don't recognise that there is an issue anyway. Within weight loss programs, up to 32% of patients meet criteria for an eating disorder, which I think is really significant. It's a big proportion of our patient group. And weight loss programs may not address and can exacerbate eating disorders. So if you think about us, asking people to focus on what they're eating, weighing themselves regularly, maybe restricting what they're eating for periods of time, it can cause an exacerbation of symptoms. So it's important that we think about these issues and are able to identify these patients. Loss of control while eating is a key feature of binge eating, and what the authors were presenting was that the gold standard assessment for loss of control eating, which is the eating disorders examination, requires specialist training, and it's a lengthy interview, so it's not something that is conducive for large numbers of patients. So the challenge to developing a measure or to having a measure in this population is that it's really difficult to assess eating disorder symptoms in individuals with overweight and obesity, because they often have very extensive dieting history, and they may not consider or report that their behaviours have been problematic. So buying diet pills over the internet and taking those, over exercising for periods of time, or excessive restriction are often seen as normal where body weight is elevated. So often people associate these kind of eating disorder symptoms as only being problematic if somebody is underweight. And what the researchers were presenting is that the people over-endorse loss of control eating on self-report measures versus clinician rated. So the eating disorders examination has a self-report measure and it has an interview version of it, and they actually found that there's no agreement between the two. So what people report on a self-report measure and what a clinician picks up on in the interview is not the same. So we don't have any, the measure isn't robustly identifying people. And they're likely to endorse cognitive symptoms even if they're not binge eating. So for example, over concern with weight and shape is generally something that is quite normal in people where there is overweight and obesity. So the authors looked at some of the existing measures out there. They looked at the questionnaire on eating and weight patterns and found that it only had 49% sensitivity in treatment-seeking populations with obesity. And the eating disorder examination, which I've mentioned before, had a 25 to 49% sensitivity. This is the questionnaire version of that. And the questionnaire didn't hold up in bariatric populations, which is really important for us to think about. And then the third one that they looked at was the risk factors for binge eating in overweight. And this actually had really good sensitivity and specificity. It was 95% and 81.5%. But what they argued was that the sample had been very small. The questionnaire was very lengthy, and actually they were, the people that they tested it on were already in treatment for weight loss. or an eating disorder and had received quite a significant amount of psychoeducation, so they might be able to better report whether they are actually binge eating or not. So the aims of this paper was to create a screening tool, a short screening tool, and to examine the sensitivity and specificity of this tool in distinguishing clinician-assessed loss of control eating from those without loss of control eating. It was to examine the sensitivity and specificity of the same items in identifying those who reported 12 objectively large binge eating episodes when assessed by a trained assessor. So they first wanted to identify people who experienced loss of control eating, and then also wanted to see if they could identify those who had kind of reached clinical thresholds, I guess, of binge eating. And they were aiming for 70% sensitivity and specificity. So they developed an online screening system with 15 items that they chose from existing screening tools and from the DSM-5 criteria for binge eating disorder. And they collected data on 365 individuals with overweight and obesity. And they did that by asking people to fill in an online interest survey, and that also included the 15 items on the screening tool. And then that was followed up with a 30-minute phone call for a clinician-assessed loss of control eating, so they had the comparison. The screening tool that they developed had 3 categories of items. It had the eating disorders behaviours, binge eating features and distress from the DSM-5 binge eating criteria, and then another category for just general overeating behaviours. And all items were to be clicked yes or no, apart from the one item was measuring distress, and that was measured on a Likert scale of 1 to 6. And they used survey logic as well, so the phrasing of the questions would differ depending on how the participant had endorsed the items. And the clinician assessed was using the binge eating module of the eating disorders examination clinician format, the interview format, sorry. For the participants that they had 364, 76% were female and 22% were male, which is not a surprise that it's overrepresented of females, and they had 0.5% non-binary or other. They were aged 18 to 74 years, and their BMI range was just over 25 to 71.87. They didn't ask any questions about ethnicity or race, but the authors gave the data that equivalent studies that they were recruiting for around the same time had 60 to 73% white, 18 to 30% African American or Black, 2.2 to 4.6% Asian, and 0 to 4.6 more than one race, and they didn't have any participants that identified as Native American or Hawaiian or Pacific Islanders. But that wasn't the data for their study, it was things that were around at the time. The key findings were 52% of participants had experienced loss of control eating in the past 3 months, which is pretty high. And they found that the self-report screener had 77.6% sensitivity and 74.1 specificity, and you can see there from the numbers that the rates were slightly different in females and males, but overall it was kind of in the 70s. And for full threshold eating disorder, so for identifying those that would meet their clinical thresholds, it was similar really, 75.2% sensitivity and 74.1% specificity. But much more sensitive in males for the full threshold eating disorders. So overall, the questionnaire was pretty good at picking up who had loss of control eating or binge eating and who didn't. But more men were misclassified than women, quite a few more men, so 30% of men and 20% of women. From these tables, you can see the items that they had. And you can you can have a look for yourselves, really. The ones that were associated with most strongly, I've highlighted those. So I felt I had loss of control while eating. And interestingly, I've experienced binge eating. So actually just asking that question in itself gave them some information. And for the full threshold, the question about making yourself vomit or taking laxatives or fasted was also distinguishing factor, which again is unsurprising really, given that that's assessing for full eating disorder. Again, this table, sorry, I can see some faces covering parts of my table, so I'll try and move them out of the way so I can see the items. This time they use statistics to differentiate between females and males and to assess which items were most effective for both. And there were differences between, so the ones highlighted in yellow were the same for both. The green ones are the ones that were for males, and the orange ones are the ones that were for females. So there were some differences between them. And I haven't gone into all the statistics because it would take quite a long time, and it's a little bit beyond me at this time in the evening, I'm afraid. So the author discussion and their conclusions were that it was a short measure with reasonable ability to discriminate loss of control eating from normative overeating, which is good. The most predictive items described binge eating or the cognitive experience of loss of control eating. And it turned out that the items that they'd taken from the DSM-5 criteria were actually not useful in discriminating between the groups, which is interesting. Surprisingly, distress about binge eating was negatively predictive of loss of control eating, and only for women. So they concluded that it wasn't really a useful metric for distinguishing loss of control eating in patients. And it was consistent with previous research that there may be gender differences between the way that people present and the items that they will score on. The items that were more predictive in men were more physiological experiences, so feeling overly full, and for women it was more psychological. And the authors recommended conducting qualitative interviews to lend new ideas and to get richer data. And they acknowledged that contexts weren't accounted for, so they didn't consider, you know, whether people were eating in a restaurant or with family and friends and those kinds of things. They didn't ask about ethnicity, so couldn't take that into consideration. And the BMI was reliant on self-reports, so there could have been inaccuracies in that data. I think from my perspective, I thought it's a really important question with a very clear clinical need. I thought their methodology generally was pretty robust. The clinicians were well trained, they'd thought through what they were doing well. I thought they were a bit unclear about the sample selection. They said that they were collecting for 5 concurrent studies at the time, and it wasn't very clear how they'd allocated people into this study over others or how those decisions were made. And so we're not able to assess for any potential bias in the selection criteria. And I think this is one of my biggest bugbears really, is that they didn't collect any data on ethnicity. So we've got no way of comparing between the groups or establishing if there are differences in the way that they have found there's differences in gender. We're not able to identify if there's any differences in ethnicity. And I think that that's quite disappointing that in this point in time, they're not collecting that information because that's how we end up with questionnaires that actually don't tell us what we need to know and don't allow people to access services in an equitable way. So I thought that was quite disappointing, really. And it was unclear how they chose their items. I wasn't totally sure how they decided what to include from different measures and what not to include, or what process had they been through for that. And there was no copy of the questionnaire published. It did say it was accessible in online supporting information, but I wasn't able to find it. So I don't know if I was looking in the wrong place, but that wasn't available to me. It was easy to complete, although I've often found that anecdotally people like more options than just yes or no, that doesn't really give people enough nuance in their answering. So somebody might say, well, actually that's happened once in 3 months. Does that mean that I have to say yes? But yes doesn't feel completely accurate. So there's a question mark there, I suppose. And they've not given any suggested cutoff scores, so I wasn't quite sure how high somebody had to score on the questionnaire before they would be considered to be experiencing loss of control eating or an eating disorder. And they don't discuss the limitations of the EDE itself, so they talk a lot about the eating disorders examination being the gold standard for these things, but they didn't actually discuss its limitations. Clinical relevance, I think it's really significant. We really struggle, as psychologists, we really struggle to find questionnaires to use in populations where there is obesity. All the questionnaires have been developed without taking that into consideration. So there's limitations of all of them. And it means that we're all using different measures and can't compare our data with each other and can't collect bigger samples of data that we can then use for research purposes.
Rachel, I'm sorry to interrupt you. We're overrunning slightly with your presentation. It's okay, no problem. Can I just ask you to wrap up in the next 30 seconds, just to allow some questions?
Yeah, this is my last slide, so I'll start. Thank you. So from a bariatric surgery perspective, we really are lacking robust measures. And we know that there is mixed evidence for the significance of this in surgery outcomes, so it feels very important. And if we were to implement something like this and we had, 30% of our patients that were identified with this, we'd need to decide what we were going to do with these people because we'd become very quickly overwhelmed. And I will leave it there. Thank you.
Fantastic, and thank you very much, and congrats on a really clear, succinct presentation. So I'm going to invite Dr. Raman Goel to take a question, followed by Mr. Vinod, followed by Professor Kerrigan.
So, Sharif, do you want me to ask a question or to?
Yes, please. Yeah, you can ask a question. Yeah.
Okay, Rachel, I think that was a very, very precise critique of this paper. And I think this was so important because this is an issue which is bothering all the surgeons in terms of bariatric surgeons, specifically because of the weight regain issues in binge eating disorder persons. So I believe you are working with a bariatric team, and I wanted you to tell me what happens if you get a patient in which you are able to identify a loss of control, and then you and the patient is not ready to change the ways or not ready to follow the treatment. How do you manage that?
Yeah, I think it's really difficult. I think sometimes when we identify patients with these kinds of issues, we do end up referring on to eating disorder services rather than putting them through for surgery, because achieving stabilisation of their eating seems to be more important than trying to lose weight. It should be the priority is stabilisation of the eating. But it's very difficult because there is really mixed evidence in this area. There are some papers that will say that actually binge eating before surgery doesn't predict outcomes after surgery, and other research that will say the opposite. So it's very difficult to know, and I think often it's a very nuanced assessment of the pros and cons and where that specific person is on their journey, and what the risks of them having surgery versus the risks of them not having is going to be. But it's difficult.
I think so, and it's a pity that this paper doesn't give you the questionnaire that they asked. How do you make it reproducible otherwise?
Yeah, absolutely. It is a shame that the questionnaire isn't included. I imagine that they will follow it up with a further study, and hopefully it's a case of watch this space and something does come out of it soon. But it is a shame.
Yeah.
Thank you, Dr. Raman. So we'll move on to, I think, one more question from Vinod.
Rachel, really enjoyed the presentation. I mean, how reliable do you think is the question of I engage in binge eating is? I mean, how people answer that is quite variable and sometimes inaccurate. And further exploration using standard definitions, it doesn't meet the criteria. So how do you view that problem?
Well, I thought it was really interesting that came up as being one of the items that was a significant predictor, because actually we know that people very frequently report that they're binge eating, but when you unpick that with them, it doesn't necessarily meet clinical criteria, and that there's a huge difference between eating half a packet of biscuits in one sitting and a true binge. And I think it's I would have said that it wasn't very reliable as a measure just to ask somebody, but it was one of the items that seemed highly predictive. So I guess maybe alongside the other items, it becomes a better predictor, but in itself, I don't think it is.
Thank you. We're moving on to the next speaker then, Tom. Thank you.
Okay, so thank you very much, Rachel. That was really good.
Thank you.
Really interesting talk and interesting paper. Next speaker is going to be Rob Tyler, who's one of our registrars at Heartlands. Admittedly, I'm trying to convert him from colorectal to bariatrics, but I don't think I'm doing very well at the minute. So we'll go easy with him on the questions. But Rob has been through the paper and he's going to present it for us. So over to you, Rob.
Thanks very much. I'll just share my screen. So everybody see that? Perfect. So as Mr. Wiggins said, I'm Robert Tyler. I am a surgical registrar working at Heartlands Hospital in the upper GI department, and here today to critically appraise a paper. Just like to thank WL Gore again on behalf of BOMS. So the paper is a randomized clinical trial on closure versus non-closure of mesenteric defects during laparoscopic gastric bypass surgery. So this was a RCT published in the BJS in January by a Danish group. So a bit of background, a laparoscopic anti-colic, anti-gastric Roux-en-Y gastric bypass has two potential sites for internal herniation. We have Peterson space and the mesojejunal defect. And studies have reported small bowel obstruction due to internal herniation ranging between 4 up to 17%. An internal herniation can present with incarceration requiring surgical intervention, or intermittent internal herniation with postprandial pain. And certain surgeons would advocate suturing the mesenteric defects closed to reduce this risk, but there were reports from case series of increased small bowel torsion at the jejunocejunectomy, increased operating time and bleeding and mesenteric hematomas. So this group sought to explore this question in a randomized fashion. So there's a single center, single blind randomized controlled trial. Their power calculation used an incidence of 0.5 to 11%, and they predicted that they would reduce the risk from 6 to 1%. And their power calculation came out as needing 422 patients, but with a 10% dropout rate, that was 464. And what's important is that the trial was terminated early on the 1st of June 2017, and that was due to a separate RCT, which was Stenberg and colleagues. It was a Swedish multi-center RCT, which had shown significant benefit of closing the defects. That was suture closure of the defects, and that was a multi-center, so that was 12 centers with bigger numbers. So they'd lost their equipoise and they closed the study early. The randomization was a 1-to-1 randomization in blocks of 4, and that was overseen by the principal investigator. They used concealed envelopes, which were opened if the patient was deemed fit for surgery when they put the camera in at laparoscopy at the beginning of the potential surgery. Blinding patients were blinded to their allocated treatment until 2 years, or if they required surgery for an internal hernia. Healthcare professionals, apart from the operating surgeons, were also blinded. Follow-up was at 3, 6, 12 and 24 months, and they used the Danish National Electronic Medical Records up to 5 years to follow up and see if there'd been operative intervention for internal herniation in that remaining period. So their outcome, so the primary endpoint was the incidence of internal herniation, and they defined it fairly clearly as herniation of small bowel through one or both of the mesenteric defects as diagnosed by CT, and importantly, or laparoscopy requiring surgical correction. They then also looked at intermittent internal herniation, which was recurrent postprandial pain and laparoscopy where at least one of the defects was open, but no hernia was present. And if the pain then resolved after 3 months, then they diagnosed this as intermittent internal herniation. The secondary outcomes were based on previous case series where they'd reported that surgery was longer. So they looked at duration of surgery, they looked at number of clips and trocars used, and post-operative pain, and that was done by the visual analog scale, and that was at 3, 6, 12 and 24 months. They also looked at post-operative complications because other studies have reported early post-operative complications, and that was done using Clavien-Dindo. They also looked at blood transfusions and the change in pre to post-operative blood transfusion, which, hemoglobin, which becomes important later on. So the procedure, it was standardized. There were 5 surgeons, they were all consultant surgeons. Doesn't tell you how experienced they were. They created a small gastric pouch. The jejunum was transected at 75 centimeters distal to the DJ. There was a gastrojejunostomy fashioned with a linear stapler via an anticolic route, and the biliopancreatic limb was connected to the alimentary limb at 120 centimeters, again using a linear stapler. And importantly, the mesenteric defect was closed with a clipper, as per Agajani et al., who have published their technique for using a clipper to do this. And this figure is quite useful. In A, it shows the standard laparoscopic Roux-en-Y gastric bypass anatomy. So we've got Peterson's space here at 1, and at 2 we've got the mesojejunal space, and then diagrams of how they close it in B and C. So I'll go through the results and what they published. So this is their consort diagram, which is fairly explicit. They had 487 eligible patients, of which 406 were randomized. There were 205 assigned to the defect being closed, of which only 4 were lost. So there's not a lot of attrition there, and only 1 lost in the non-closure group. And the 4 that were lost were, the operation was terminated. In 2 cases, 1 they couldn't close Peterson's defect due to an anatomical variant, and 1 they had anesthetic difficulties. We look at baseline characteristics, evidently because it's an RCT, they don't have to show p-values. Any difference between these 2 groups should occur by chance, but they're pretty similar in terms of age, sex, and the preoperative BMI, and also comorbidities. When we look at the preoperative hemoglobin, they use millimoles per litre, which is different than grams per deciliter, but I've looked it up, it's about 14 and they're virtually the same. And the post-operative pain as well. This is an important takeaway figure. It's a Kaplan-Meier showing the cumulative incidence of internal herniation against time, and you can see after a year that the non-closure group breaks away from the closure group, and there is a significant difference in the incidence of internal herniation, and we've got a p-value of 0.004 on a log rank test. When they compared the groups, there was 2 significant findings. I wonder if I move that away there. So the duration operation was longer, significantly longer in the closure group by 4 minutes, but in their discussion they think that's not significantly or clinically significant, which I would agree with. Interestingly, there was a significant difference in bleeding. So there were 4 cases of intraoperative bleeding in the closure group. There was also significantly more blood transfusions required postoperatively, and this change is roughly just over a unit, and this is about 0.8. And they concluded in their discussion that this was statistically significant, but was unlikely to be clinically significant. I think that's something that is up for debate. And then importantly, if we compare the grade 3B Clavien-Dindo complications, there was 9 in the closure group and 5 in the non-closure group, which was not significant in this paper, but they did see similar percentages in the Lancet paper, which had a much larger number, and that was significant at the time. Of those 9, if you look at the small print, there was 3 due to bleeding, 3 due to torsion at the jejunoctomy. There's 1 iatrogenic bowel injury and 1 relaparoscopy. I've put a supplementary table in because in the abstract they talk about the fact that at 2 years the incidence of internal herniation was not significantly different between the 2 groups, with a p-value of 0.1, and they say at 5 years it was. But when you look at the supplementary table, you can see that actually after 3 years they do become significantly different, whereas the rate of internal herniation is never different, and hazard ratio remains roughly the same at about 2.6. So I've gone for strengths and weaknesses of the trial. It's a randomized control trial, and I think the group should be applauded. Performing randomized control trials is very difficult, and especially in surgery, and they standardized the procedure, which limited its variability. And there were pretty good numbers, especially for an RCT, with a median follow-up of 5 years. It was the first randomized control trial to be published that looked at clips versus no clips. And they published their consort statement and also their study protocol. And I think they acted ethically in the fact that they stopped their study early when the Lancet paper was published. For weaknesses, it's a single center, which I suppose is a double-edged sword. So there's reduced external validity. The learning curve of the surgeons is not extrapolated on. We don't know whether they were learning the clipping technique from the start of the study or whether they already had it established, and that may have caused a larger number of bleeding events, for example. The discussions around intermittent internal herniation are not, it's not fully explored, and I think the definition of it is slightly woolly in the study itself. And it wasn't significantly reduced. They use concealed envelopes, and the blinding process can be subverted with concealed envelopes, as we know, through light or looking in them beforehand. And a central computer randomization is the gold standard. There wasn't a cost-benefit analysis. It would be nice to know how many clips they used. I couldn't find that even on the supplementary data, because compared to something like a non-resorbable suture, I'm sure there is a significant difference. And lastly, there was early termination of the study. And so technically they failed to recruit the number of patients required to power the study. So importantly, what's the clinical significance? I think that it's randomized evidence, and it's the second trial to show good evidence of lowered rates of internal herniation with a negligible increase in operating time. Importantly, there were higher bleeding rates, which they slightly brush under the carpet in the discussion. Whether we think that's clinically significant is for debate. So I personally think that this does change management. You've got 2 randomized control trials showing that you should close the mesenteric defects, but so I'll go back here. The key question, the next question is, how do you close these defects? The Swedish trial was sutures, this is clips, and I know that there are certain centers that glue as well. But whether you can power an RCT to look at that and explore that question is another matter. So thank you for listening, and I've importantly just put my references there as I've screenshotted all the papers. Thank you very much.
So lovely talk, Rob, and thanks for sticking to time. And I'll invite Dr. Rahman to again ask the first question.
Rob, wonderful presentation. You know, an important issue that most of the surgeons face in gastric bypass. I think the challenge of this RCT is primarily the ethical issue, with so much data on closure, benefits of closure. Not offering it to a group of patients is an ethical issue. If I'm on the ethical committee, I'll be asking more probing questions to approve a study like this. And also the definition of intermittent internal herniation is also because one group where it wasn't closed, any pain, you go there, you will find a defect. And so that will increase the number of internal herniation rates higher. And third thing that I find is the clip closure is not the most commonly done method of closure of the defects. And that is why if you see even in that group where the closure was done, you see that red graph going up with the time. So I'm certain that there were patients who were having internal herniation even with closure. Did you see the percentage of people who had internal herniation with the in closure group?
There was certainly one in the Clavien Dindo, so that's early post-operative complications. There were one of the 5 was an internal hernia in the closure group, but the percentage I'm not quite sure of. I do have the supplementary table here though.
While you're looking for that, Rob, I can answer the first question about whether it's ethical to do another study about non-closure. And I think you're right, it's probably not anymore. And I think that's one of the important reasons they stopped this trial early, is because actually the Stenberg data became available. So they felt they couldn't be not offering closure to everyone. So I think the question now is, how could we organise a study looking at the different methods of closure and what's the most effective? Now, the problem is, rather than going from a effect size of 5%, you're probably going to have to look at a different endpoint to organise a study and try and power something. But I think that's probably the next question that is going to need to be answered, really.
Yeah. I think the sample size would be a big issue when you have different.
Absolutely.
Yeah.
So there are 13 internal hernias in the closure group compared to 31 in the non-closure group. So yeah, they still get internal hernias when you close, and it goes up every year. The mechanism of that I'm unsure of, but.
Rob, just in the interest of time, we'll move to Prof. Kerrigan to ask the next question, if that's okay.
So Rob, I was just going to say, what a perfect example of a brilliant way to do a presentation of this kind. I was going to say, it was similar really to Raman's question, is we've still got, I think even at 3 years, a 5% internal herniation rate in the closure group, I think, from the supplementary table you popped up there. And I guess we always, with these studies, it also depends on how hard you look for a complication. When you're looking at complication rates after surgery, and maybe in a randomized trial like this, people are looking a little bit harder than they would do in normal clinical practice. But 5% did seem quite high in the closure group for me at a relatively early stage. I just wonder what your comments on that were.
Yeah, I agree. I did wonder about the blinding process of the surgeons, because I thought in theory, if there's only 5 surgeons and someone comes in with abdominal pain and you know that you've closed their mesenteric defect and they've got abdominal pain, how hard are you going to look to see if they've got an internal hernia? Whereas if you know you didn't close their defect, that you might scan them, you might re-laparoscopy them earlier, so you would find higher numbers. Well, I don't know though whether that becomes significant over time. I'm not sure.
Yeah, particularly when a CT diagnosis was an acceptable diagnosis. I suppose easy to get a CT scan done, isn't it? And the specificity of CT scanning for internal hernias is not that great. So I think there are a few weaknesses in this, but a really interesting study to pick out. And thank you very much for doing such a good job.
Oh, thanks a lot.
And Rob, we're trying to tempt you to bariatrics. We're working hard with Todd. So just one more question from Roxana, and then Prof. Kerrigan will make a short announcement.
Thank you. And thank you, Rob, for representing the trainee side and engaging with the Journal Club. I've got just a quick question about surgical trial methodology, really. So they had over 480 that they identified, and then only 80 patients, I think, had declined to enter the trial, which is pretty good in terms of surgical trials and recruitment for an interventional one like this, especially a blinded one. Did the authors, or did you have any thoughts about how they managed to get such a successful recruitment rate?
They certainly don't mention it in the paper. I don't know if that's just a sort of nuance of the patient group. Is it that they want an operation? And I suppose the explanation of equipoise, if the surgeons consenting them had said we genuinely don't know the difference, and then and they're after weight loss surgery, then they'd have been more likely to go ahead. I don't know. Maybe I'm looking at it from a bariatric angle. What would you think?
Well, I think there are definitely lessons to learn in terms of also the other examples that we've had here with the buy-band sleeve. I think that 16% in terms of people declining it is good, and perhaps it was because both operations were similar and it was technique for the internal hernia, I guess, as to preventing complications rather than that. But I think, you know, certainly there's, if the authors could develop on that, or we could consider that for future trials.
I think the other thing to remember, Roxana, is as evidenced by the fact they stopped it early, this study was before we had the Stenberg paper, and actually we clearly defined what we should be doing with the internal hernias as well. So actually, in terms of the equipoise, it was there when they were recruiting people. So
it's always a topic that we can literally discuss for hours and hours.
Absolutely.
But just in the interest of time, I just want to put another plug out for our two next dates. So 26th of May is the educational webinar, 9th of June is the next journal club run by the Imperial team. And I'll just hand over to David Kerrigan just to make a short announcement and then close the meeting. But thank you all for tonight.
Thanks very much, Sharif. And so just while we've got a bit of a captive audience and before you all log off, I just wanted to remind you all that BOMS is running a face-to-face annual scientific meeting in Oxford on the 5th to the 7th of July. That's a Monday to Wednesday. The training day is a Monday and the main meeting on the Tuesday and Wednesday. So we absolutely would be delighted to have as many of you as possible attend that meeting, and it will be the first face-to-face meeting, I think, for about 18 months for all of us. So it'll be, I think, a really fabulous time. We've got a great program put together. The other thing just to remind you of is there's a huge discount for the registration rate for the meeting for BOMS members, and that all of us who are BOMS members, our membership of BOMS runs out at the end of May. So there's also a membership drive Fran is doing to get everybody to sign up again so that you can take get advantage of that much reduced rate for registration for the annual scientific meeting. So we'll be sending stuff out fairly shortly. Please remember that BOMS as Society is the specialist UK bariatric society. It devotes all of its time 100% to bariatric matters, and it's the place to be, I think, if you want a good career in bariatric surgery. So with that plug for BOMS and for the meeting over, I'll hand you over to Sharif to wind the meeting up. And thanks once again to the Birmingham team. Fantastic meeting.
Yeah, thanks, David. And thank you to the speakers, the panelists, the sponsors, our guest, Dr. Raman Goel, and all of you for attending, and good night.
Thanks.
Right.
Good night.